Hi, good afternoon. Actually, that was pretty good, sure honest. So, yeah, thank you. I want to ask everybody to think back real quick to your 9th grade English class. I know that's an obscure request, but the reason for that is I would guess that was the first time you saw this poem, and I know that's where you saw it because every 9th grade English teacher is obsessed with Robert Frost. It's like the Beatles in the 1960s to them. But the poem, if it's been a few decades, presents a wanderer in the forest who becomes keenly aware that there's not one but two paths ahead of him. And he's lamenting over the fact that he can only take one. And I think this is very analogous to where we are in interventional glaucoma today. As every physician in here knows, there's not one pathway for physiologic outflow, there's two in the eye. The trabecular meshwork and the uveoscleral pathway. And when we look at the market for interventional glaucoma purely by the natural outflow pathways, an interesting story starts to emerge. And I guess you have not seen this analysis presented before, but I want to walk you through it. So just looking at the glaucoma industry in terms of the physiological outflow therapy. So I'm removing surgical diagnostics, taking out blood-forming procedures. When we look at the clinic, where agents targeting both pathways exist, we can see the uveo pathway dominates. Not only is it 3x the volume, but it's now regularly cited to be first line. I would guess any physician in here is using prostaglandins routinely. And it's important to understand why that is clinically. Because between the two natural pathways, the uveoscleral pathway has the greatest capacity for outflow, not just in terms of anatomical size, but there's no countervailing force against it called episcleral venous pressure. So there's no restriction to flow. But this story gets really interesting when we leave the clinic and walk through the operating room doors. That same surgeon, in fact, that same patient, when it's now time to take an interventional approach, is limited wholly to the trabecular meshwork pathway. Nothing available in the uveoscleral space. And as a marketer or an investor, this is a classic unmet need example. There's so many questions to ask about this. So clearly there's precedent for clinical belief, but no solutions available. And the next question you might ask is, well, where would that fit in? The trabecular pathway has a ton of technologies today, often used at the time of cataract surgery. That slide showed, I think, 13, now it's up to 14 or 15, with several more coming in the coming quarters. But what happens when a surgeon treats those patients at the time of cataract surgery and opens the first of the two natural pathways, you end up with a lonely path toward blood-forming procedures where sometime 2-3 years later, efficacy will begin to wane because the disease always wins. And those surgeons do not have good options. This is where they'll say, you know, I got to put the patient on more meds, or unfortunately, they're going to be moving toward a blood-forming procedure. And our market analysis showed there's actually 2.5 million living eyes in the US today that are pseudophakic post-MIGS with signs of that waning efficacy. This is a real patient problem to solve for. And the reason why it hasn't been addressed in the past, we're not the only ones to see this unmet need. Our thesis is it's an issue of material science. And this is where the move from interventional to biointerventional medicine solves a lot of unique challenges. And we've already seen this pioneered in the orthopedics and spinal surgery space using homologous natural tissues and cells and bone to solve problems. And this is what we're doing at Iantrec in interventional glaucoma, launching biointerventional. So this is the first and only homologous natural tissue implant used in interventional glaucoma. It comes preloaded, provides access to the uveoscleral pathway. We are in pre-market launch today. It does have CPT codes. It's profitable surgeon reimbursement today, both for the facility and the physician. It is available, but we're broadly launching later this year. We're in the process of completing our Series C round right now and closing out that syndicate, at which point we'll complete scaling up and be ready for AAO launch. If you look at the right, that's a real-world case. This is the first time you're seeing a glaucoma implant literally made of the same material as the tissue surrounding it. You can see it's completely clear of the AC. There's nothing protruding into the anterior chamber. It's left flush. The animation on the left shows the two steps, a creation of a small cyclodialysis cleft, insertion of viscoelastic to maintain that pocket, and then insertion of the preloaded device. So surgeons are not surprised when they see the efficacy data, knowing the power of the uveoscleral pathway. We've published now both 1- and 2-year data. At 2 years, we're sustaining over a third reduction in continued IOP decrease, and also over a 60% reduction in medication reliance on those patients. But the real star of the show is we're not seeing any significant safety issues because we're using homologous natural tissue conforming to that space. This has been designed from the ground up for corneal safety. So I'll bring you back to our opening story. Unlike our traveler in the beginning in that poem, we do not believe that there's a single path to choose, but this will open up complementary treatment to allow physicians to take a complementary natural physiologic approach to targeting these disease states and staying inside the angle. Thank you very much.